Hello and welcome to part 6 of the Consultation Skills course. I'm Dr. Alex and I work at the Christian Medical College in Vellore in South India. In part 1 we saw the benefits of good consultation skills, how they are about providing better care for our patients, not just about being a nicer doctor or other health professional. In part 2 we looked at the Calgary-Cambridge Guide to the Medical Interview, looking at the 5 phases and 2 running themes in every consultation. And in part 3 we looked at power and control in the consultation and how that can help or hinder good communication. We saw that as a health professional we need to give some of our power to the patient so that their agenda can be fully expressed. This is the big idea and is otherwise known as patient-centeredness. Instead of the health professional being at the centre of the consultation, they help the patient to take the centre spot. So what do we need to do? We are aiming in the consultation for a meeting of experts. In the last presentation we learned about the 4 of 3 essential skills we can use. The golden minute, allowing the patient to tell their story in their own words for up to 1 minute without interrupting. Now we come to essential skill 2, which we will call DICE. This section is about understanding the patient's perspective on the problem. DICE stands for difference or disability, ideas, concerns and expectations. Now when you look at books about this, you get variations on these letters. Sometimes you get ICE, ideas, concerns, expectations. Sometimes you get FIFE, feelings, ideas, function, expectations, and there are others. Ideas and expectations seem to be constant. The other letters may vary. I use DICE as it is important to get some idea of the impact of the problem on the patient's life, and I think concerns is an easier concept for most of us to understand than feelings or other options. Remember, we want a shared expert conclusion, a coming together of the disease and the illness experts. DICE is a technique to help us do this. So, D is for difference or disability. What is the effect of the problem on the patient's life? What does it stop them doing that they want to do? 2 patients with exactly the same problem may have very different answers to this question. A manual labourer with a mallet finger on the little finger of his left hand will suffer almost no disability from it at all. A professional violinist with the same injury may lose his livelihood. Take a little time to understand exactly what the problem is. One way to ask this might be to say, what difference is all this making to your normal activities? I is for ideas. An idea has been defined as every opinion the patient may have about a possible cause, diagnosis, treatment or prognosis of the issue they come with. If the patient thinks their headache has been caused by their neighbour putting a curse on them, it is helpful for the health professional to know that. It may help when we discuss treatment options. If the patient thinks the cough he has may be related to the number of cigarettes he smokes each day, then that will help us discuss giving up smoking with him. One way to talk about ideas might be to ask, have you any thoughts about what might be causing this or what we could do about it? You may find it helpful to think about how you would ask these questions in a language in which you consult with your patients. C is for concerns. Is there anything about this problem which concerns you particularly? Here is a personal story on this. I have gastroesophageal reflux on and off, and I've had it for years. I usually buy some antacid ranitidine from the pharmacy, and it works very well. About 5 years ago, a friend of mine who is the same age was diagnosed with gastric carcinoma and died within 1 month. I went to my family physician to discuss my reflux. I was 99% sure it was simple GORD. But because of my friend's problem, I wanted to be 100% sure. I had a gastroscopy, and all was well. Patients come with concerns. They are concerned that their headache might be a brain tumour, like their auntie had. They are concerned that the ulcer on their foot will lead to an amputation, like their neighbour's grandfather. As they lie awake at 3 o'clock in the morning, the slight pain they have in their chest due to the cold they caught from their 3-year-old son gets magnified in their thoughts into a heart attack. Most patients know their concerns are probably irrational. but they are still concerned. If we do not address the concerns in the consultation, the patient will feel dissatisfied and will either come back a few days later or, more likely, go to another doctor. E is for expectations. What does the patient expect, hope, or wants to happen as a result of the consultation? Are they expecting to be sent for a specific sort of investigation, like an X-ray? Were they hoping for the medicine their friend got for their cough, which worked like a miracle? When I went to talk about my GORD, I was hoping, wanting, yes, probably expecting to be referred to a gastroscopy. I would have been quite upset if the doctor had told me not to worry, because it's probably just reflux. I knew it was probably just reflux, but I wanted to be 100% sure. Some expectations are realistic, others are not. The 20-cigarette-a-day smoker is hoping for a miracle cure for his cough, which is impossible, but needs to be discussed. The man with 1 week of mechanical back pain is expecting to be sent for an X-ray or an MRI, neither of which will actually help in the management of his problem and will cost a lot of money. Some expectations we can meet, many we cannot, but if we do not discuss them, the patient will not be happy, and we have not reached our shared expert conclusion. This question can be very difficult to ask. I usually say something like, "Is there anything you hoped I would do for you when you came to see me here today?" Think about how you might ask this in a language you consult in. So, DICE. Difference, ideas, concerns, expectations. As always, use open, then closed questions to clarify what the patient has said. If you have not found out already, ask then about past medical problems, family history, current medication, what they are actually taking, not what has been prescribed, and about allergies. Once again, summarize what you understand about the patient's illness to clarify what's going on, and move on to the next phase, the physical examination. As an exercise for this part, look at the second part of the consultation between Dr. Duncan and Mrs. Jackson. How well does he use this part of the consultation to gain an understanding of her illness? If you're using YouTube, this is consultation video 2. Use the transcript if you need to.